Welcome to Dermatology Discussions. In this discussion, we are focusing on the histopathology of the glomus tumor of the nail bed. And I want you to imagine a very specific, but honestly incredibly classic scenario. A patient walks into your clinic complaining of just agonizing paroxysmal pain right under their fingernail.
Oh yeah, the classic presentation.
Right. And they tell you the pain becomes absolutely unbearable the moment they wash their hands in cold water. You take a close look at the digit, and you notice this faint red streak running down the nail plate, a longitudinal erythronychia. What exactly is going on there?
Well, I mean, that presentation is just a screaming red flag. Anytime you hear about severe cold-induced subungual pain coupled with that visual cue, your mind really should immediately jump to a glomus tumor.
Exactly. And our goal today is for you to completely master these core concepts, the clinical signs, the exact histopathology of glomus tumors, so you can easily recognize them on the ward and, absolutely nail your dermatology board exams.
Pun intended, I assume.
Obviously. But to truly understand why this tiny lesion causes such disproportionate suffering, we'll cover the normal function of a glomus body, the pathogenesis, the histopathology at low and high power, and, crucially for the boards, the specific stains you must memorize.
Right, because before we can understand the tumor itself, we have to understand the normal anatomy. I mean, what is a glomus body even doing in the finger in the first place?
Yeah, that's the perfect starting point. We know they're concentrated in the reticular dermis, especially the digits, the palms, the soles.
Yeah, mostly the nail beds. And they're essentially these highly specialized arteriovenous shunts. Their entire functional purpose is thermoregulation, so preserving the core body temperature through, vasoconstriction and vasodilation.
Right, because normally blood flows from an artery into a capillary bed and then to a vein.
Exactly. But the glomus body bypasses that capillary network entirely. It provides a direct microscopic connection between an afferent arteriole and an efferent venule. And the crucial structure in the middle of all that is the Succoy canal.
I always like to picture the Succoy canal as kind of a biological smart plumbing valve, like it's wrapped in this muscular jacket. But what exactly makes up this jacket surrounding the canal?
So that jacket is made of normal glomus cells. And this is vital. These are modified smooth muscle cells. That is their cellular origin.
Because they have to regulate the vessel tone, right?
Right. They possess contractile properties, so they express smooth muscle actin, or SMA. And they're heavily innervated by unmyelinated C fibers, which are the nerves that mediate pain and temperature.
Okay, let's pause and explicitly repeat that for everyone listening because it is that important. Glomus cells are modified smooth muscle cells, and they are innervated by unmyelinated C fibers.
Yes, lock that into your brain. Because once you internalize that specific cellular makeup,
Yeah.
the whole clinical picture just clicks into place.
So now that we know the smart plumbing valve exists to control temperature, what happens when one of those parasite-like glomus cells undergoes a neoplastic transformation?
Well, it typically starts as a clonal expansion. A single cell starts multiplying and forms a well-circumscribed encapsulated nodule.
And that tight encapsulation is what sets up the classic pain triad that you'll definitely be tested on. All right. Let's break down the why behind those symptoms. First up, the paroxysmal pain.
Think about all those unmyelinated C fibers we just talked about. As the tumor expands, it's pushing outward, but the fibrous capsule is resisting.
So it's basically a pressure cooker.
Exactly. Those abundant nerve fibers are literally being compressed within a closed space. That mechanical crush is what causes the sharp episodic pain.
Okay, that makes sense. Then the second part of the triad is the cold hypersensitivity, the patient wincing at the cold tap water.
Right, because the cells retain their thermoreceptor function, but they're mutated. So they respond to cold cathologically with this intense, violent vasospasm.
Which clamps down the vessels and causes immediate ischemia.
Yes, and that localized hypoxia forces the tissue to dump out pain mediators like substance P and bradykinin, which causes that excruciating pain spike.
Wow, okay. And the final piece of the triad is point tenderness, elicited by the love test.
Yeah, using a pinhead to apply pressure. Because the tumor is so small, like 2 to 5 millimeters, and trapped under the nail, even pinpoint pressure deforms the capsule.
And instantly crushes those nerve endings again.
Exactly. It's an agonizing mechanical trigger.
But wait, this brings up the Hildreth sign, which I find fascinating. If you apply a proximal tourniquet to the finger, the pain actually goes away. Let me play devil's advocate here. If the finger is already in ischemic pain, why does cutting off the blood supply with the tourniquet stop the pain?
It's a great question. And it's a mechanical puzzle. You have to think about the hemodynamics. When you apply proximal compression, you reduce the arterial flow going into the tumor.
Oh, I see.
Because it's an arteriovenous shunt, the tumor is incredibly vascular and engorged. When you cut off the inflow, the tumor actually physically shrinks. It deflates.
Because there's less vascular engorgement.
Exactly.
Yeah.
And that deflation decompresses the capsule, which gives those screaming nerve endings a break. The pain vanishes. Release the tourniquet, the blood rushes back in, the capsule stretches, and bam, the pain is back.
That is so cool. It perfectly proves the structural hemodynamics. So we know what it looks like in the clinic. But what happens when we biopsy this painful subungual nodule and look at it under the microscope? Let's zoom in on the histopathology.
At low power, the first thing you'll notice is a well-circumscribed encapsulated nodule sitting right there in the reticular dermis, or the nail bed dermis.
And importantly, no epidermal involvement, right?
None. It's strictly dermal. And at this low power, you need to categorize it into one of the three Masson variants.
Okay, let's list those out clearly.
The most common, at about 75%, is the solid glomus tumor. As the name implies, it's mostly solid sheets of cells. Then you have the glomangioma, which is roughly 20% of cases.
And that one is more vascular.
Yeah, it has prominent, widely dilated vessels. It actually resembles a cavernous hemangioma structurally. And finally, the rarest is the glomangiomyoma at about 5%.
I'm guessing by the myoma part, it has smooth muscle.
Spot on. It features prominent bundles of normal-appearing smooth muscle blending into the stroma.
Okay, so assuming we're looking at the standard solid variant, let's switch to high power. What's the signature look of these neoplastic glomus cells?
They are incredibly uniform. You're looking for round to cuboidal cells with very well-defined, distinct borders. They have a central, perfectly round nucleus and this pale, eosinophilic cytoplasm.
And there's a classic artifact you see on H&E stains that examiners love to ask about, right?
Oh, the perinuclear halo, yes. You'll often see a clear space, a halo right around the nucleus. It's just an artifact from the tissue processing shrinking the cytoplasm, but it's a very reliable visual clue.
We also have to emphasize the vascular component here. Inside the tumor, you have these blood vessels, but they are lined by completely flat, normal endothelial cells.
Exactly. The glomus cells do not line the vessels. They form cuffs or collars around the outside of those normal endothelial channels.
It's like they're hugging the pipes. And I really want to repeat this for memorization. When you're looking at these cells, there should be no atypia, no pleomorphism.
And no mitotic figures. Absolutely. Benign glomus tumors are mitotically quiet.
If you see mitosis, you are not looking at a standard benign glomus tumor, period.
Right. You need to start thinking about a malignant process at that point.
So on a board exam, just recognizing the cell morphology isn't going to be enough. You need to prove their identity using immunohistochemistry or IHC to rule out the copycats.
And the absolute gold standard stain for a glomus tumor is smooth muscle actin SMA. Because, like we said, they are modified smooth muscle.
So you'll see strong, diffuse cytoplasmic positivity with SMA.
Exactly. You might also see positivity for calponin and, importantly, Keldesmin.
Why is H-Keldesmin important?
It helps distinguish it from a myopericytoma, which can look similar, but is typically negative for H-Keldesmin. Oh, and Vimentin will be positive, too, confirming the mesenchymal origin.
Nice. And what about that famous architectural pattern we look for with special stains?
The chicken wire pattern, yes. If you use collagen type IV or a PAS stain, it highlights the basement membrane that surrounds each individual glomus cell.
So it literally looks like a chicken wire fence mapping out every cell.
It's a beautiful interlocking grid, highly characteristic.
Okay, I want to pose a deliberate trap question for our learners here. Since this tumor is essentially a vascular malformation full of blood vessels, shouldn't the tumor cells stain positive for CD31 and CD34?
That is the most common pitfall. It's a great trap. The answer is no. You have to separate the two cell populations. The endothelial cells lining the vascular spaces inside the tumor are CD31 and CD34 positive.
Because they're true endothelial cells.
Right. But the glomus cells themselves, the cells actually making up the neoplastic mass, are completely negative for CD31 and CD34.
That is such a key distinction. It beautifully distinguishes it from a true hemangioma. In a hemangioma, the tumor cells themselves would be CD31 positive and SMA negative.
Exactly. In a glomus tumor, it's the reverse for the neoplastic cells. SMA positive, CD31 negative.
So what else are these cells negative for? What is it not?
Well, they're usually negative for desmin. Even though they're smooth muscle, desmin is a marker of fully differentiated smooth muscle. So a negative desmin helps distinguish it from a true leiomyoma.
That makes a lot of sense.
And crucially, S100 is negative.
Which is huge because that rules out some scary stuff.
Oh, absolutely. It rules out a subungual melanoma, which you really don't want to miss. It also rules out benign neural tumors like schwannomas or neurofibromas. And finally, cytokeratin is totally negative.
So let's lock this differential pathway into your brain. If you have a subungual tumor plus it's SMA positive plus it's S100 negative, that equals a glomus tumor.
That is the exact formula you need for test day.
All right, so we've diagnosed it perfectly, but let's look at the bigger picture. What happens if this tumor is left alone for years? And are these always just random, sporadic events?
Well, on the genetics front, about 90% of them are completely sporadic, isolated lesions. But about 10% are actually familial.
Oh, wow, I didn't realize it was that high.
Yeah, and the familial cases are linked to a mutation in the GLMN gene. That's the glomalin gene located on chromosome 1p21 to 22.
And how do those patients present differently?
Instead of just one painful fingernail, they usually present with multiple glomuvinous malformations spread across their body.
That sounds awful.
Mhm.
And going back to the late stage evolution of just a standard tumor, if a patient leaves this tightly encapsulated nodule under their nail for a decade, what does that do to the bone?
Well, the constant pulsatile pressure actually erodes the underlying distal phalanx. If you take an x-ray, you'll see this well-defined, smooth cortical lucency right on the bone.
Like a little pothole carved into the phalanx. But that's just pressure atrophy, right? Not malignant invasion.
Correct. The margins are smooth and corticated, which tells you it's a benign, slow-growing process pushing on the bone, not destroying it aggressively.
Speaking of aggressive, let's answer the ultimate patient question. Can this become malignant?
Progression to a glomangiosarcoma is exceptionally rare. I mean, it's almost unheard of for most standard cases.
But if it did, what would the pathologist have to see to make that call?
You would need to see profound chaos, marked cytologic atypia, areas of deep tissue invasion, frank necrosis, and specifically more than 5 mitotic figures per 50 high-power fields.
Which goes back to our earlier point, if you see mitosis, be highly suspicious.
Exactly. But generally, simple surgical excision is completely curative. You take it out, and the patient's lifelong agony from cold tap water is just cured instantly.
It's amazing how such a tiny, localized histologic anomaly completely dictates the patient's clinical reality.
It really is. And, as you're reviewing all of this for your exams, I want to leave you with a fascinating linguistic connection to ponder.
Oh, I love these. Let's hear it.
The word glomus actually comes from the Latin word for a ball of yarn.
Oh, wow. A ball of yarn.
Right. And when you think about the normal glomus body and the encapsulated tumor it becomes, it is quite literally a tightly wound spherical labyrinth of vascular channels and sensitive nerve fibers.
That is such a brilliant visual.
So next time you see a patient wincing from cold water on their finger, just picture that tightly wound ball of yarn unraveling right under the nail bed.
That's perfect. Like, subscribe, and share for more content like this.